Hello, everyone. Thank you for being here and signing in. Thanks for being here during these strange times. I hope everyone's doing well and taking care of themselves and their loved ones. My name is Sean Crooks. I'm one of the R2 emergency medicine residents. And if you're like me, for the last little while, you've been pretty immersed in the COVID topic. And I hope that you guys find it refreshing to talk about something that, other than COVID. Been around a bit longer, but similar to COVID, is not entirely straightforward. During the broadcast, if you have any questions, please just type them into the Q&A, and then I'll get to them at the end. And if you have any technical issues, please put them into the chat, and Aaron Peterson is monitoring that dialogue box to help you out with anything in that respect. Okay, perfect. So vertigo is something we see very commonly in the emergency department. And it's a troubling problem for us because it's the symptom of a large range of diagnoses, from the benign to the life-threatening. And in most cases, we have to rely pretty heavily on our history and our exam to make the diagnosis, without as much help as from imaging as we normally get from other presentations. And vertigo is just one type of dizziness. There's other types. There's lightheadedness, pre-syncope, disequilibrium. But today we're going to mainly focus on vertigo, which is the illusion of motion. So here are the players today. And the million-dollar question is my patient having a stroke in their cerebellum or brainstem, or do they have a benign problem in their inner ear? And just some numbers to get us motivated this morning. So 4% of patients that come into the emergency department have a chief complaint of dizziness and vertigo. 5% of those patients are having a stroke, and 35% of those patients, those strokes are missed on first presentation. So, you know, we still have our work cut out for us in this topic. So how do we know if our patient's having a stroke or if they have a peripheral problem? Well, apparently the truth lies here in the eye. And the question is can we actually find it? And you probably have the same thought as me, is that you're thinking the truth lies in the organ that's probably the most ignored in all of medical education. So it's hard to find. This gentleman here is the face of vertigo. His name is Dr. Newman Toker. He's a neurologist from Johns Hopkins. And this man is a publishing machine. He's published hundreds of papers on vertigo. Almost every paper I reviewed had his name on it, which makes it nice. It made my life a bit easier because the literature is so consistent. The approach to vertigo and all the papers basically have the same messaging, which is nice. But I do think that there's some bias in the literature. If Dr. Newman Toker likes something, like for example, the HINTS exam, which he created, I think it may be overstated sometimes in the literature. So just keep that in mind as we go through the talk. The objectives for this morning are we're going to learn a new way to classify patients with vertigo based on the timing and triggers and not based on the type of dizziness they have. We're going to learn about associated symptoms that are suggestive of stroke. We're going to talk about high-risk patient factors that are suggestive of stroke, and physical exam and imaging controversies. So the approach we're going to learn comes from, of course, Dr. Newman Toker, and it was first described in a paper in Clinics of Neurology in 2015. They made a mnemonic called the titrate mnemonic. It was again discussed in a paper in stroke in 2018 with Tirani as the first author, Newman Toker as the last author. And the mnemonic is titrate. Basically, you start to classify patients on the timing and triggers of vertigo, and then you review their associated symptoms, and then each classification has a targeted exam associated with it. So if you want to take a second, if you're interested in having those papers, those QR codes will take you to those papers. To solidify the approach, we're going to apply it to a case throughout the presentation. This is a real case, a challenging case that came to the Foothills a few months ago. So it's a 31-year-old female who presented to the Foothills with sudden onset headache and vertigo. The story was she was lying in bed and had sudden onset headache. About 10 minutes later, she had very severe vertigo with nausea and vomiting. She could barely make it to the washroom. She had to hold herself up on the hallway to get to the washroom. So really challenging gait. It was constant vertigo, but it was worse with movement. She had no associated symptoms with it other than the headache, but no brainstem symptoms, no motor symptoms, no sensory symptoms. She was an otherwise healthy female. Her vitals were normal. Her neurological exam was normal, although she didn't have any special maneuvers like a Hintz exam done. Her labs were normal, and she had a non-con CT head that was normal as well. And she was discharged with the diagnosis of vestibular migraine. So this doc just walked in the room of a dizzy patient, and he's about to ask his very first question. What do you think he's going to ask? He's going to say, what do you mean by dizzy? We all ask this question, and because a lot of us were taught to classify vertigo based on the type of dizziness. Unfortunately, this is a very unreliable way to start your differential diagnosis for vertigo. Patients just have a very challenging time describing their dizziness experience. And this has been shown over and over again in the literature. So there's a paper by Edlow in 2013 that showed that if you ask patients to describe their dizziness and then go in there 10 minutes later and ask them to do it again, their description will be completely different. Again, Newman-Toker did a study on this, and he took patients with known pathologies. So they had known stroke, known vestibular neuritis, known migraine, and asked them to describe their dizziness. And again, the type of dizziness was very inconsistent and unreliable. And then Kerber did a study on this in 2006 and found that no matter what type of dizziness, what word you use to describe your dizziness, so presyncope, lightheadedness, disequilibrium, vertigo, they all predict stroke with the same likelihood. So bottom line is that classifying patients based on the type of dizziness should not be how we generate our differential diagnosis. We should be using the timing and triggers. And this is the TI and the TR from the titrate mnemonic. So how we do this is we classify these patients into 3 categories. And I'm going to introduce these 3 categories, and then we're going to talk about them in a bit more detail in the subsequent slides. And what you'll notice is that each of these categories has dangerous causes of vertigo within them and benign causes of vertigo within them. So the first one is triggered episodic vestibular syndrome, which is obviously triggered by patient standing up or patient moving. Dizziness that lasts under a minute. They don't have it when they're just sitting there. And this is most commonly BPPV, orthostatic hypotension, or CPPV. Then we have our spontaneous episodic vestibular syndrome. So these people have vertigo happening when they're just sitting there at rest. It's worse with movement, but it's happening when they're not moving. And this is lasting minutes to hours, and this is most commonly vestibular migraine, Meniere's, or TIA. And then we have acute vestibular syndrome, which is constant vertigo lasting for days. And this is most commonly viral vestibular neuritis or labyrinthitis, but can often be a stroke. So let's go through those in a little bit more detail. So if we have triggered episodic vestibular syndrome, this is BPPV, BPPV, BPPV. The classic story is the patient rolls over in bed and they're spinning, okay? This can also be orthostatic hypotension if the patient is getting dizzy from standing up. And then we need to think of like GI bleeds, ectopics, et cetera. They kind of veer off the pathway and into different differential diagnoses. And then we have CPPV, which is, to be honest, something I'd never heard of before preparing for this talk, but it's quite rare. So I'm not going to talk about it too much, but basically usually a little cerebellar infarct, presents exactly like BPPV with triggered episodic vestibular syndrome. It's usually discovered weeks later when the patient doesn't get better with an Epley maneuver. The only clue you might get is on the Dix-Hallpike, they won't have fatigable nystagmus or torsional nystagmus. So then we have spontaneous episodic vestibular syndrome. So remember, this is happening when their patient's just sitting there. It's, of course, worse with movement, but it's not triggered by movement. And it usually lasts for minutes to hours. Now, this is most commonly vestibular migraine. So the one thing I want to say about vestibular migraine is that usually it's a recurrent process by definition. It's an episodic recurrent process. So you have to be a little bit wary to be the first person to make the diagnosis of vestibular migraine. You kind of want them to have the story that they've had it before, and this is the same. The other thing about it is they still have to qualify for the migraine based on the other features of migraine. So the photophobia, phonophobia, etc. And then we have Meniere's disease, which is overproduction and underresorption of endolymph in the cochlea. Now that can cause tinnitus, oral fullness, and vertigo. And just like migraine, it's a recurrent, should be a recurrent process. So you kind of like them to have the story that they've had this before. And again, be a little bit wary of being the first person to make this diagnosis because you don't want to miss TIAs. And we're going to talk up later on in the talk about how to risk stratify for TIAs. Okay, this is the big one. Acute vestibular syndrome is constant vertigo, spontaneous nystagmus, gait instability, and nausea and vomiting. So constant vertigo. And the spontaneous nystagmus is actually quite prevalent in the first 24 hours. So you'll walk in the room and you'll see their eyes beating, okay? And this is most commonly viral vestibular neuritis, which is viral prodrome and then is essentially like a Bell's palsy of the 8th cranial nerve. If they have any hearing loss with that, it's called labyrinthitis, but this can be a posterior circulation stroke. So 10% of patients with constant vertigo, so with acute vestibular syndrome, are having a stroke. If they have one vascular risk factor, 30% of patients with acute vestibular syndrome are having a stroke. So we really need to have our spidey senses on for this. And these posterior circulation strokes, they can swell and then the brainstem get hydrocephalus and it can push on the brainstem and they can die a few days later. So that's the big reason why we don't want to miss these posterior circulation strokes in acute vestibular syndrome. Okay, so we've done the first two parts of the titrate mnemonic, the timing and triggers. Now let's get into the associated symptoms. So the nice thing is there was an article in 2011 by the CMAJ that reviewed all these associated symptoms and all the kind of case series data that came before this paper and gave a strength of a prediction for stroke for each of these associated symptoms. So I'll try and mention that for each of them. And if you want to scan this paper as a QR code there, I'll just leave that up for a second. Okay, so neurological deficits. If our patient has vertigo plus neurological deficits, I think all of us are worried, okay, which with good reason. And we're quite good at asking about all the on history and testing for it on exam, but we ask about the Ds usually. So the diplopia, the dysarthria, the dysphagia, the dysphonia, so hoarseness of voice, and then sensory motor and sensory loss and motor loss as well. And these are high yield questions. If you look at this paper from Kerber in 2006, they looked at 1,600 patients with dizziness and vertigo, and they classified them based on the ones that had stroke and the ones that had no stroke. And you can see that the patients with stroke, more than half of them had motor deficits. And then about a third of them had sensory, language, and visual deficits. So you can see that these neurological deficits are quite prevalent in the stroke patients. And the CMAJ review article suggests that any neurological deficit is a strong predictor of stroke. If you look at this another way, if you look at it with patients with just vertigo, no associated symptoms that we can detect, how many patients present in that way? Well, the Kerber paper showed that about 20% of patients with stroke and TIA had no focal neurological deficits, just isolated vertigo. So that's interesting to think about. And it's actually almost on the lower end. Some of the other studies I looked at, they weren't as good as this study, but they had up to 30 to 40% of patients who presented with isolated vertigo were having a stroke. And this is actually even more common in TIA. There's a paper in The Lancet in 2013 that showed that 90% of posterior circulation TIAs were missed on the first presentation, and half of those had isolated vertigo initially as a first presentation. So the bottom line is that neurological deficits are strongly associated with stroke, but their absence is not a good predictor of stroke. Okay. Postural and gait instability. I think this one, again, we know this is bad. If your patient can't walk or your patient can't sit up, that is highly concerning. And the Kerber paper would agree with you. So basically, instability was deemed to be the strongest predictor of stroke in that paper. And CMAJ paper would also agree, saying that any postural gait instability is a very strong predictor of stroke. And there's honestly no controversy in this one. And so we'll just leave it at that, that if your patient can't sit up or walk, think of a central cause. Okay, now let's talk about head and neck pain and vertigo. So of course you can have head and neck pain and vertigo with a vestibular migraine. But remember, vestibular migraines by definition should be recurring. Okay, and you kind of want them again to have those other features of it. The diagnosis you don't want to miss with this one is vertebral artery dissection, which is actually quite commonly misdiagnosed as vestibular migraine, especially in young patients. And young patients won't often have that classic story of vert dissection where they had a chiropractic manipulation or a trauma. They won't have that story very often. So we really need to think about this diagnosis because 70% of patients with vert dissections progress to having a stroke. The only thing that's helpful, or the one thing that's helpful, is there's a good amount of literature to suggest that the pain in vert dissection is quite different than the pain in a vestibular migraine. So the pain is quite sudden onset. So sudden onset head and neck pain plus vertigo, we need to be thinking about vert dissections. And it's much more severe and sustained pain than vestibular migraine. Some of the case studies showed that these vert dissection pain, neck pain and head pain last for 35 days. So that will be our biggest clue. Back in 2011, the CMAJ article called this a moderate strength predictor of stroke. So vertigo plus sudden severe head and neck pain, think of a vertebral artery dissection. Okay. The next one is kind of a new kid on the block. So it's vertigo plus hearing loss. And if you look at this image here, you can see that the ICA artery, the anterior inferior cerebellar artery, comes off of the basilar, and it perfuses the entire inner ear. So if you have a stroke in the ICA artery, you will lose perfusion to your inner ear and you'll have vertigo and dizziness. And ICA strokes are the second most common type of brainstem stroke. They're not that common, but they happen. And there's a group of studies by Lee that showed that 80% of these ICA strokes will have sudden hearing loss. And there's a study by Chang that found that the combination of sudden hearing loss and vertigo is actually more predictive of stroke than just vertigo on its own or sudden hearing loss on its own. And Newman-Toker decided to jump on board this bandwagon in 2013, when he published the HINTS Plus exam. So he wasn't overly satisfied with the 96% sensitivity of the HINTS exam, so he added hearing loss to it in 2013, and he just used the the finger rubbing test to see if there's a difference on each side, and that bumped up the sensitivity of the HINTS to 99%. And Dr. Peter Johns actually wrote an article about this in the CMAJ just in February, if anyone's read that, and where he endorses the HINTS Plus exam. So in summary, vertigo plus sudden hearing loss, we need to think of an ICA stroke. Okay, so vomiting. Vomiting out of proportion. I really wanted this to be a pitfall of stroke workup, because there was a study I read with missed posterior strokes that said vomiting out of proportion was very common in these missed posterior strokes. It kind of clouded the diagnostic picture. But the more I read, and when I spoke with some of the stroke neurologists, I realized that vomiting can be very severe in peripheral vertigo as well. And it really doesn't help us distinguish peripheral vertigo from central vertigo. So really there's not much, patient vomiting a lot doesn't really help us distinguish between central and peripheral causes. So in summary, focal deficits and inability to walk or stand are strong predictors of stroke, and that's based on a CMAJ review article. Sudden severe neck pain is a moderate predictor, and hearing loss back in 2011 was an unknown predictor of stroke. I think that if the study were to be done now, there's enough evidence to show that's probably a moderate predictor of stroke. Okay, so let's go back to our case for a moment and just apply what we've learned so far. So we've learned about classifying patients based on the timing and triggers. Now, this is challenging because you could argue that she was 3 hours into her vertigo presentation and she still had vertigo in the emergency department. We saw her at 3 hours though. She was feeling a little better with some gravel and Maxaran, but still had vertigo. So you could argue that she's acute vestibular syndrome or she's a spontaneous episodic vestibular syndrome. Either one would be correct at that point. I mean, later on, if you saw her a day later, you call her acute vestibular syndrome, but at that point in time, you could argue either one. And then the second thing is in terms of associated symptoms, she had nothing other than a sudden onset headache. So we'll park that for now, and then we'll finish up the case later on in the presentation. So the titrate mnemonic doesn't actually apply patient factors until after the mnemonic is done and later in the approach, but this is the right time to talk about it in the presentation. So of course, it's important to know if your patient has risk factors, vascular risk factors, such as diabetes, hypertension, smoking, connective tissue disorder, previous strokes, etc. And there's good reason to ask those questions and find out about that, because if your patient has more than 3 vascular risk factors, there's a study to suggest that their risk of stroke is 5 times higher. And one way to risk stratify patients based on vascular risk factors is something you might recognize from the TIA literature, but it's actually been studied in vertigo in the last number of years. It's the ABCD2 score. It hasn't been prospectively studied, it's been retrospectively studied a few times. But basically, if you apply the ABCD2 score for vertigo, if the patients have a score of under 3 or lower, there's a study by Navi et al. On 1,000 patients, and what they found was that if your score is under 3, you have a 1% chance of having a stroke. So it's kind of nice to know. As it gets higher, so if it's anywhere between 4 and 7, it bumps up to about 6%. And then Newman-Toker studied this as well back in 2013, and he did it on patients with acute vestibular syndrome and 1 vascular risk factor. And what he found was if your score was 4 or greater in that group, that's 60% sensitive for detecting stroke. So you might want to, it's something to put in your toolbox as something you can use for vertigo patients to risk stratify. Okay, so we're nearly done the titrate mnemonic. Sorry, just flip to the extra slide there. We are on the last part, the targeted exam. And it's called a targeted exam for a reason, because each category in this Tehrani Newman-Toker approach, each category of vertigo gets a special extra little exam or piece of history. So everyone with vertigo or dizziness gets these 3 exams. So everyone should get a neurological exam with scrutiny to the cerebellum, so finger to nose test and rapid alternating movements. Everyone should get sat up in bed and walked. And then everyone should get a hearing screen, so just the finger rubbing screen. Okay. And then if you have triggered episodic vestibular syndrome, you should have a Dix-Hallpike test. So I think we know about the Dix-Hallpike. Basically, patients sitting up in bed, they look over 45 degrees, they sit back and hyperextend their head back, and then they should exacerbate their symptoms, usually on one side. If it doesn't work on one side, you do the other side. And there's a 5-second latency period, and then you'll see torsional vertical nystagmus. And this is really the only time we can accept torsional vertical nystagmus. If you see torsional vertical nystagmus spontaneously in a patient without doing a Dix-Hallpike, that's quite worrisome for stroke. But in a Dix-Hallpike, it's actually a normal finding. And then it should be fatigable. So if you repeat the test, their vertigo should be fatigable. So this is a picture of the road to hell. And the road to hell is paved with good people doing Dix-Hallpikes on patients who don't qualify for the test. The problem with the Dix-Hallpike is if you do this test on anybody with dizziness, like first, if they have a stroke or migraine or whatever, you will make their symptoms worse. And you might think they have a positive Dix-Hallpike test because of that. So you really have to nail down the diagnosis of BPPV on history before you even do this test, because you'll get very confusing results if you do it on too many people. Okay, so the next category is our spontaneous episodic vestibular syndrome. So remember, that's our vestibular migraines, our Menières, and our TIAs. And other than the three things that we did for everybody, the neuro exam, the gait and postural instability, and the hearing test, these patients also get an ABC2 score to risk stratify them for TIAs. And there's lots of data lots of studies on TIAs and ABC2 score, so it's well validated. So this is the tool that is suggested in the Tarandi-Newman-Toker approach to risk stratify patients. Okay, so then we're on acute vestibular syndrome, which is the big one, the one we're worried about. So these patients get a HINTS plus exam. So really, when you think about, and the HINTS plus, remember, that's the addition of the hearing loss. So the thing about this is that you can kind of see that the same patient really shouldn't ever get like a Dix-Hallpike and a HINTS exam. They're kind of separated earlier or more upstream. So I'd like to talk a little bit about the HINTS exam now. So the HINTS exam was released in 2009 from Newman-Toker Studios. Huge release, lots of buzz. Everyone was very excited about it. It was done on 100 patients with acute vestibular syndrome, and 75% of those patients had stroke, so pretty sick population. And when they qualified for the test, the neuro-ophthalmologist would get paged and come strutting into the emergency department and perform the test. And the sensitivity of the HINTS exam was 96% for detecting stroke, and the sensitivity of a diffusion-weighted MRI in the first 24 hours was 88%. So you can see how this was pretty exciting test. And I'd like to actually, I hope you bear with me while I go through the exam, because when I met with Dr. Subramaniam from Stroke, he wanted me to pass on some pearls about the HINTS. And we all know that we can use more review about the HINTS. This exam is something you need to review quite frequently if you're going to use it. So the first part, I changed the order a little bit. So I start with nystagmus. And the reason I'm starting with nystagmus is that for two reasons. First of all, it's less invasive. And second of all, it's you kind of have to have nystagmus to actually do the head impulse test, or else you'll get a confusing result. And the head impulse test was only validated on patients with nystagmus. So for the nystagmus, you basically just take your pen or finger, and you have the patient move their eyes laterally. And you're looking for whether they have unidirectional nystagmus, which is suggestive of an ear problem, so the eyes kind of beat towards the problem, or they have bidirectional nystagmus, where the eyes beat bidirectionally, or they have no nystagmus. And so bidirectional and no nystagmus are worrisome for stroke. Okay, so problem is that patients can actually like fixate on something on the wall and suppress their nystagmus, so you won't actually be able to detect it. So one tip that Dr. Subramaniam showed me is having a little piece of paper here on the side, so that if you can suppress their fixation by having a little piece of paper. So have them do the test this side, and then put it on the opposite side and suppress fixation that way. And then the second part is the test of skew. So that's the cover-uncover test. And what you're looking for is a little upbeating of the eye, which is called skew. And that's suggestive of stroke. Okay. Dr. Subramaniam told me that an easier way to do this is if the patient has skew, they'll have diplopia. So instead of doing this, you can just ask the patient if they have diplopia. If they have diplopia, they have skew. If they don't have diplopia, they do not have skew. And then finally, the head impulse test. So patient's looking at you right in the eyes, you're holding their head, and you move it over about 20 degrees to the side, and you snap it forward. And you're looking for a corrective saccade. So the eye will beat away and beat back. And that's suggestive of an ear problem. Okay, if they don't have that, that's worrisome for stroke. So let's go through that again. So the HINTS peripheral, and you should try and document this HINTS peripheral. If you documented HINTS positive and HINTS negative, that's kind of confusing. So try and document this HINTS peripheral or HINTS central. You have to have all three of these things. So you have to have unidirectional nystagmus, tests of skew, so you have to have no skew or no diplopia, and you have to have a catch-up saccade. Okay. If you're having trouble seeing the catch-up saccade, one tip I heard is you can use the patient's phone, so you're not using your own phone, and video it and see if you can catch it with that. Have someone else video it. And then a HINTS central would be if you have bidirectional or no nystagmus, you have skew or diplopia, and you have no catch-up saccade. Okay. So now that we've gone through it, let's discuss the HINTS exam. So we've had 10 years to think about this, and I've been thinking about this a lot in the last couple months, but the HINTS exam has really not been validated by us in our population yet. It was done by neuro-ophthalmologists in pretty sick patients, 75% of them having stroke. There was a study in Italy in a few years ago that looked at trying to validate this in emerge docs. It was a small study, and these emerge docs underwent extra special training, and they had Fresnel goggles as well. So I still don't think that's a good validation that shows that we've actually, that emerge docs can use this test with a good sensitivity. It's often applied inappropriately. So if you apply this test, if you do a HINTS exam on someone who's dizzy because they're having like a GI bleed, they won't have nystagmus and they won't have a catch-up saccade. You might think they have a stroke. So it can be very confusing. And if you do that enough, you lose trust in the test. And I think people get frustrated with it. It's often underutilized. So there's a study in Ottawa and a study in Montreal a few years ago that looked at how often emerge docs are using this test. And it showed about 5 to 7% of patients with dizziness were getting this test done, which is actually appropriate because only about 5 to 7% of patients would actually have like constant vertigo and nystagmus and qualify for the test with acute vestibular syndrome. But if you look at the charts, there wasn't really, a lot of the patients that had it done were not constant vertigo patients. And I think the more concerning thing with that study, with the Ottawa study, was that the documentation was very unclear. So half the documentation was kind of inconclusive. So it would say like HINTS positive, HINTS negative, which you could kind of argue either what that means. And then a lot of them had the findings written out, but had the interpretation incorrect. So it would have the findings and then interpreted as HINTS central, HINTS peripheral, incorrectly done. So there's still work to do in that department as well. And I think we can all agree that this test is very confusing to interpret. There's a survey study that came out in 2015 that says that emerge docs think this is the hardest exam that we do. So I've been thinking about this a lot, and where do I stand on the HINTS exam and how we should apply it? And I've talked to Stroke about this. I've talked to a lot of emerge docs about this and some neurologists, and I think I've landed on a reasonable stand on this. And I'm curious to hear what other people think in the Q&A. But I think that we should do this exam. I think that it should be used as something to make us more worried if we're going to rule in stroke. So if we do the exam, we think these things are central, we work the patient up more. But should we be using it to rule out stroke? I think that there's a very small population of patients that you can use this to rule out stroke in. This is the perfect patient. So patient with acute vestibular syndrome, who's young, who has no associated symptoms, they can walk, they have no neuro deficits, they have a good story for vestibular neuritis and a perfect HINTS peripheral. I think that patient you can save a CTA and use the exam. But other than that, I think we're going to be using it more as a bit of to make us more worried. So bottom line, by my opinion, is that in most patients, the HINTS should not be used as a rule-out test for stroke. Okay, let's keep it rolling into another controversial topic, imaging in vertigo. So let's talk about non-con CT heads in vertigo. Are they a worthwhile test? The answer is no, they are not. They're really only going to see a large bleed, a mass, or a chronic infarct. They are very insensitive in looking at pathology in the posterior fossa. There's too much bone artifact down there, and if it takes a while for parenchymal injuries to show up on dry CT heads in the posterior fossa. So the sensitivity is 16 to 40% sensitive for detecting stroke in the posterior fossa. So really, really low sensitivity. It's actually a bit of a dangerous test. There's a study in Ottawa in 2015 that found that if you had vertigo or dizziness and a non-con CT head done, your chance of stroke in 30 days was double as if you did not have a non-con CT head done. And the reasoning for that is that these patients got CT heads because someone was worried about their presentation, and then they were falsely reassured by a poor sensitivity test. So really, there's not much role at all for non-con CT heads in vertigo. How about CTA? Well, CTA is quite a bit better. The reason why it's better is that it is reliable for vessel imaging. So the patient's got horrible atherosclerosis in the posterior vessels, or if they have stenotic vessels or a dissection in the posterior vessels, we will see that. And that is actually something we want to know about for making sure they don't have a recurrent stroke and making sure we can have them on secondary prevention. So when I spoke with the stroke neurologists about this, they are quite happy with us using this as a risk stratifier for patients who are worried about stroke. The sensitivity for this test is it's not that much better at parenchymal injuries than dry CT head. It's about 45% sensitive for parenchymal injuries, but it's like over 90% sensitive for vessel pathology. So vert dissections, stenosis, atherosclerosis, etc. It's as good as MRI, and with a very good negative predictive value for recurrent stroke. And that's based on a local study actually in 2012 called the CATCH study. And what they did in this study was they had patients with minor stroke and TIAs who underwent CTA and diffusion-weighted MRI on the first visit. And looking at those images, they were able to rule out the risk of recurrent stroke with a negative predictive value of 96% in 90-day recurrent stroke. So basically, CTA was the same negative predictive value as diffusion-weighted MRI. So the stroke neurologists say that this is a great risk stratifying tool for recurrent, making sure the patient doesn't have a recurrent stroke in the next 90 days. Now we have our golden child, the diffusion-weighted MRI, which is the elusive test. And it's actually elusive for maybe a bit of a good reason. In the first 24 hours, it's actually not an unbelievable test. It still misses 20% of posterior fossa strokes in the first 24 hours. It gets better from 24 to 48 hours. It kind of jumps up to about 88% sensitive. And then after 48 hours, it's close to 100. So it actually makes sense that if the CTA would be a better first test initially in the emergency department, and then the patient can get admitted if it's concerning, and then have the MRI the next day through stroke. So in summary, for imaging, there's really no role for the non-con CT head in vertigo. CTA is readily available and has a very good negative predictive value for recurrent stroke. And MRI is usually going to be done in consultation with stroke. So how are we doing in Calgary from an imaging perspective? Well, this is data from the last 4 years, all Calgary sites. It's 19,000 patients. And you can see on the y-axis, we have the percent patients imaged. And on the x-axis, we have the imaging modality. So you can see about 20% of patients had non-con CT heads. About 10 to 11% of patients had CTAs. The turquoise bar is those two combined. And then the MRI is about 3% of patients. So let's talk about this data a little bit. So how are we doing in comparison to other places? So we're doing better than the States. So in the States, they image with CT imaging 35 to 50% of dizzy patients. So we're doing better than the States. And in Ottawa, there's a study in 2015 that showed the CT rate for dizziness and vertigo was the same as ours, 20% CT rate. They didn't have any values for CTA. I've heard that we have a slightly higher CTA rate than Edmonton. And I asked the stroke neurologists what they thought about this, and they are quite okay with this. They say that we have a lower rate of recurrent strokes because we use CTA more often, and they're happy with us using a $300 test on the initial visit for patients who are worried about stroke, rather than having a $3,000 recurrent admission for stroke with the morbidity that comes with that. So they were quite happy with us using our CTA rates. My thoughts on this is I'm looking at this blue bar with the non-con CT head, a nearly useless test in vertigo, and that's our most used test. So why don't we bring down the non-con CT head rate? And maybe that'll free up some cash for more CTAs, or maybe not. Maybe we don't even need more CTAs, but at least let's bring our blue bar down. If we look at the same data, this is just plotted over time. The blue bar is the non-con CT head. The red bar is the CTA, and then the green bar is MRI. So you can see the non-con CT head. We've gone down a little bit in rates for that. We've gone up a little bit with our CTA rate, and we've stayed about the same for MRIs. Okay. So now we've kind of gone through most of the content. I'd like to just talk about our case. So our patient was arranged by, on her own to be seen by a neurologist a couple of days later and had a diffusion weighted MRI ordered. As she was leaving for the MRI, she had another sudden onset of vertigo, very severe, like could not get up off the floor, and was driven to the MRI and was vertiginous in the MRI machine hours later, and then had an MRI that showed she had bilateral vertebral artery dissections and a posterior cerebellar stroke. So what can we learn from this case after now going through the whole titrate mnemonic and approach? Big things for me that I see in this case, and remember we're looking at this in retrospect, so we have a huge advantage, is young people with no vascular risk factors can still have strokes. And the stroke that's commonly missed in them, the stroke syndrome, is the vertebral artery dissection. So we need to think about that in these patients. Another thing is the sudden onset headache. I think we think of subarachnoid hemorrhage, and that's what was thought about in this case. It was trying to rule out subarachnoid hemorrhage with the non-con CT head. But it would be rare for a subarachnoid hemorrhage to have vertigo as well. So so sudden onset headache plus vertigo, I think vert dissection needs to be high on our differential for that. Another learning point from this case is the non-con CT head and how it failed us again in this case. I think we would have seen vert dissections with the CTA in this case. And finally, I think the last learning point was perhaps a HINTS exam maybe would have increased our suspicion of central cause in this case. So it could have been done as well. Okay, so before we get into recommendations and in terms of a pathway for vertigo, I wanted to just talk about what we can do for these patients, just briefly. So essentially, the guidelines for posterior strokes are the same as anterior strokes. There's really no differentiation in the stroke guidelines about posterior and anterior. It's still all based on NIHSS scores. The amount of data that supports these decisions in posterior strokes is much less, especially around thrombectomies. Most of the data in thrombectomies is on anterior strokes, but you can still lyse a patient with TPA in the first 4.5 hours of the posterior stroke. These patients can still get thrombectomies in the first 6 hours up to 24 hours. But most of the time, what's going to happen is these patients are going to get secondary prevention with blood pressure lowering, cholesterol control, diabetes control, and antiplatelet therapy. So the guidelines are basically the same for anterior and posterior strokes. So I'm going to present a clinical pathway for vertigo based on what I read. And it's actually interesting because a couple months ago, or about a month ago actually, I found out that there was a pathway that was created by a group of emerge docs a few years ago that was actually rejected by the executive because it was thought that it was going to lead to too many CTAs. And the pathway I kind of created on my own was very similar to this pathway. So we kind of independently created the same pathway. And I've looked at other pathways from other places, and they are very similar as well. And the stroke neurologist would really like us to have a unified emerge pathway for vertigo so that the workup is consistent, and they are very much in agreement with the pathway that was created a few years ago. So my hope with this talk is that we can maybe resurrect that old pathway and get it back on the table for more discussion. So the pathway I'm going to present is kind of simplified, but it's kind of nice for presentation purposes, I hope. So essentially, if you have any high risk features, then you're probably getting imaged. So if you're over 65, you have the worrisome associated symptoms that we talked about. So you can't walk, you have focal neurological deficits, head and neck pain, and hearing loss. You're kind of looking towards getting imaged. And if you have more than 3 vascular risk factors or an ABC2 score over 3. So we're going to break it up by category. So the triggered episodic vestibular syndrome category. So this is our most commonly BPPVers. These are the ones that you probably don't have to image. They are the classic BPV story with a consistent Dix Hallpike and nothing else. You don't have to image those patients. Epley maneuver, vestibular physiotherapy, and then you're done. If they're worrisome for stroke for whatever reason, they have high risk features, then yes, they may warrant imaging. Next is our spontaneous episodic vestibular syndrome patients. So these are our migrainers, our Meniere's, and our t-IVS. And there is a subset of these patients that probably don't need imaging. And those are the ones that we talked about earlier, where they've had this recurrent story for vestibular migraine, they've had this recurrent story for Meniere's, and nothing's changed. I think you can probably avoid a CT scan on those patients. But any high-risk features or worries for TIA, those patients should be imaged and consulted. And then acute vestibular syndrome. So constant vertigo, and we're worried about stroke. Remember, 10% of these patients without any vascular risk factors are having stroke. So I think there is maybe that perfect patient that exists as well that maybe doesn't need imaging. And we spoke about that with the HINTS exam. So that's the perfect story for vestibular neuritis, no associated symptoms. They're young and healthy. Those patients, and a reassuring HINTS, you might be able to avoid a CT on those patients. But I think in general, most patients with acute vestibular syndrome will be getting imaged and consulted. And you know what? We don't see that many acute vestibular syndromes. Anyways, it's usually only about 5 to 10% of patients with vertigo that have actual constant vertigo. So this won't really increase imaging by that much, I don't think, if we're imaging acute vestibular syndrome patients. And obviously, if they have atypical or high-risk features, then those patients need imaging. So in summary, we learned about an approach to vertigo that's based on timing and triggers, and less about the type of dizziness, but more about classifying based on the timing and triggers. We learned to be worried about vertigo plus. So if your patient with vertigo has focal deficits, they can't walk, head and neck pain, or hearing loss, or vascular risk factors, we need to be worried about those patients. Triggered episodic vestibular patients, those are their BPPV patients, and they get a Dix-Hallpike, and if it's consistent, they can go home. Spontaneous episodic vestibular patients, these are the ones that our migraines and our Meniere's and our TIAs, and we can risk stratify those patients with our history, physical, and an ABCD2 score. And acute vestibular syndrome patients, constant vertigo, spontaneous nystagmus. We can use the HINTS exam as a data point, but these patients will often end up needing imaging. And there's very little role for non-con CT heads in vertigo. And CTA is a much better test for negative predictive value of recurrent stroke. So thank you all for your attention. And these are the people who contributed a lot of help to this presentation, and I'm very thankful for that. Thank you very much. I'm just gonna have a look at the questions. Looks like there's 12 questions that have popped up throughout the presentation. Okay, so I'm going to try and answer as many of these live as I can. So we have 12 minutes. So question from Aaron Johnson saying, I think we should stop trying to remember how to do this exam and use a cognitive aid to walk us through the test and record findings appropriately. I totally agree with that. That's a great thought, and that would actually be pretty easy to make. So maybe I can work on that. Ian Walker, my neurologist wife has an expression that has stuck with me over the years as I struggle with vertigo. In quotations, if you're thinking of making the diagnosis of vestibular migraine, just don't. That's good. I'm not sure if people want me to read these out loud, but I'm going to go ahead and do it. Okay, there's one from Sean Fair here. It says, I think what he means is HINTS should only be applied to patients with continuous vertigo syndrome, i.e. acute vestibular syndrome. If you don't have resting or gaze-evoked nystagmus when you've appropriately visually suppressed them, paper or bright light, then they technically don't enroll in the HINTS as was studied. Okay, let me just, yeah, so I struggled with this as well. So basically, to qualify for the HINTS exam, you really want to have constant vertigo, and it's very helpful to have the nystagmus, because in the HINTS study, these patients did have spontaneous nystagmus. So all the head impulse test studies, which has actually been very well studied, is actually the best part of the HINTS exam. They all had spontaneous nystagmus, or nystagmus that could be identified with the test. So it's important for these patients to have nystagmus. So Nick, I think no nystagmus makes head impulse test not useful, as likely not to have corrective saccade with no nystagmus. How no nystagmus indicates central versus peripheral, I think, is difficult. How no nystagmus indicates central versus peripheral is difficult. I don't think that's really a question. I think it's Nick just kind of talking to Sean. So there's another question from Deborah Obu saying, I think the confusion in the interpretation can deter the ED physicians from applying the hints. I agree. And it's a very challenging test that you have to almost review every time you do it. And it can be a deterrent, which is why I think it's important to use it as more of a rule-in test. And if you're going to use it as a rule-out test, then you need to really make sure you're up to speed on the components of it and the nuances of it. So it needs to be practiced. And it's something we don't do very often because it's not that many patients have acute vestibular syndrome. Okay, so Art C saying CTA needs to be approved by the RAD in Edmonton, so there's a bias against them doing them in the ED. That's interesting, I didn't know that. And Eileen said, is radiology on board with CTA and Vertigo? Yes, they are. I spoke with some of the radiologists, and the radiology literature is very supportive of using CTA, especially for vascular pathology. So vert dissection, stenosis. Okay. Sorry, the questions are coming in fast and furious here, so it keeps jumping my screen. So Kevin Hanrahan, doing a test hints that we can't even figure out as a group when to do this is likely not very reliable. Perhaps in a resource poor environment, but not Calgary. Yeah, I thought about that a lot, and I think that you're right. It's a hard test to do, and it's not as maybe there's going to be lots of hints inconclusives that are done. But if we don't practice this test and we don't do this test ever, we're gonna lose our skills in this test. And the neurologists think we should be doing this test. Dr. Subramaniam from Stroke thinks we should be doing this test. There's some variation. Dr. Hill from Stroke is not as keen about it, but this test, I think, is another data point that's helpful. I kind of think of it like a white blood cell count. Like if you're working up a patient for an API, it's nice to know if they have an elevated WBC count as a data point. It's not going to really change your decision as much, but at least it's something else in a confusing diagnosis to add to our toolbox. So I don't totally agree with not doing it completely. Ben Shepard saying a recent meta-analysis in Academic Emergency Medicine, March 13th, is supporting my conclusion that hints alone performed by emerge docs is not sensitive to rule out stroke. I haven't seen that article. That's awesome. Thanks, Ben. So Anj Pandya is saying, Sean, did the stroke team say anything about whether or not they want to see these patients in stroke prevention clinic, i.e. multiple vascular risk factors, but relatively normal CTA? Yeah, so I did talk about this with Dr. Surya and Dr. Hill. So they are very happy. Neurology is very happy to see patients in stroke prevention clinic or TR clinic the next for worrisome presentations of vertigo with a normal CTA. Because I didn't know this, but the TR clinic, the only difference, those clinics are essentially the same, but the TR has MRI capabilities that day, so they can get seen the next day and then have an MRI while they're in office. So they're very happy to see. And the other thing I'll say too is that I talked with ENT as well, and ENT is also very happy to see any diagnostic uncertainty within a couple days, especially around Meniere's or even an abnormal kind of BPPV that has some strange features to it. They're very happy to see those, and they see them actually within a couple days. The neurovestibular clinic, the one that Dr. Subramaniam works out of in South Health, their wait list is like 6 months because they do 1 hour consults. So they're not really a useful resource for us. Okay, so Kelsey McLeod, maybe I misheard. In order to do the HINTS exam, there should be nystagmus. Yes. So that is so the head impulse test was only validated on patients with nystagmus. And so you can do the whole HINTS exam on patients, so starting with the nystagmus, but if they don't have spontaneous nystagmus or you don't see nystagmus showing up on the first part of the exam, they're very unlikely, they're not probably going, it's probably going to be a kind of a confusing head impulse test. So the best the best patients to do the HINTS exam on are the ones that have constant vertigo, and you walk in the room and they have spontaneous nystagmus. Those are the patients that the HINTS is validated on. Okay, Gord Jewett saying, I think it's important to remember that HINTS exam is made up of components of a neurological physical exam, and the information from those maneuvers can be helpful regardless of the role they played in a specific trial. Yeah, totally fair. Okay, so Aaron Johnson posted an article here that's saying atypical patterns in subarachnoid hemorrhage include dizziness and vertigo in a study with poor outcomes in this group. Muddies the waters in this area. Yeah, I agree with that. I didn't know that study existed, but thank you for pointing that out. Sorry, my screen is jumping a bit. There's lots of questions here. So Jonathan Lubin saying, you mentioned that inability to walk is a high-risk feature. Does this apply to people with triggered episodic vestibular syndrome? It seems that many elderly patients with BPV cannot walk steadily. Yes, that's a good point. I think that the inability to walk is definitely a high-risk feature. There's no question about that. If your patient can't walk, especially an elderly patient, it kind of affects two things. It increases their likelihood of stroke, plus it also makes it kind of dangerous to send those patients home. They could come back with a broken wrist or a broken bone. So I think there's two parts to that, but the inability to walk is very highly suggestive of stroke. But if you have a patient with a perfect story for BPV and a Dix-Hallpike that is consistent with that, I think you should be pretty reassured that that is BPPV. But in an elderly patient, that is a risk factor for stroke as well. So you have to there'll be some judgment there whether or not that patient actually fits into that category. If you think of the pathway I guys generated, it was the perfect patient for BPV has Dix-Hallpike and no high-risk features. Being elderly is a high-risk feature. So you have to use the judgment there and decide if you want to image that patient. And plus they may need to be admitted anyways because they can't walk and they're elderly and there might be risk for them to go home. Okay, Sean's just said to John saying, Sean Fair saying, John, I would consider that high risk in a t-EVS patient unless they had clear rotary nystagmus on a Dix-Hallpike to confirm BPV as a diagnosis. In the elderly with an unclear history and no clear rotary nystagmus, can't walk, I consider that high risk. Yeah, I totally agree with that. Amanda Schreiner says, sorry, my screen jumped again. I was always taught not to do the Dix-Hallpike or HINTS in the patient who has no nystagmus, as these tests are not helpful in the situation. I've heard of hemiplegic migraine, but not of vestibular migraine. Is that like abdominal migraine? I still don't know what that is either. So vestibular migraine is, but the definition of it is the same as the migraine definition that we learned in med school. So, but they have the one extra feature they have with it is vertigo. So they still have to meet that criteria. The definition is identical except for that one additional feature. And I'm just seeing if there's any more questions within there. I think you can do you definitely can do the Dix-Hallpike in patients without nystagmus because you're going to evoke the nystagmus because patients with BPV usually don't have spontaneous nystagmus. So you can definitely do the Dix-Hallpike. You should be doing the Dix-Hallpike on those patients without, and then you will evoke nystagmus with the maneuver. And then the HINTS one, I think the HINTS, you're going to try and elicit nystagmus as much as you can with the first part of the HINTS exam. But I would complete the whole exam regardless of if you see nystagmus or not on the first one. Okay, so Colleen, there's a big difference between walking independently with a bit of unsteadiness and not being able to walk. Yeah, for sure. It's high risk when they fall or have to hold furniture constantly, for sure. Okay, Zach Urquhart saying, could you clarify the sensitivity of CTA for ischemia outside the vertebrals? So in the ICA, the PICA, and the pontines. Yes, I can. It's the same. So the sensitivity I said was for all posterior circulation. So if sensitivity for any stenosis or dissection is over 90% for all posterior circulation. I think we're out of time.